Actually, see, the topic is role of anesthesia or the anesthetist. Whoever is a good colleague of you for many of the years, going to be a good colleague of you in the future. Okay, because when Madam has given me this topic, I have almost forgotten about this session actually. 15 days ago, I think Divya, she reminded me about all these things, sir. I have sent you already all the details of the session. I have gone through what I have to write or what I have to think to tell everyone. Because తెలుగులో మాట్లాడాలి అంటే రాయలసీమ సైడ్ అయితే ఒక మాట చెప్తారు, అరే కాన్పంటే పునర్జన్మ రాని. రాయలసీమ సైడ్ మామూలుగా మంచి తెలుగులో చెప్పుకోవాలంటే పురుడు పునర్జన్మతో సమానం అని అంటారు తెలుగులో మాట్లాడుకోవాలనుకుంటే. ఒకవేళ తెలుగు రాని వాళ్ళకి ఎవరైనా చెప్పొచ్చు ఇంగ్లీష్లో కానీ హిందీలో కానీ. అంటే వెనెవర్ ఈవెన్ టు మై అనస్థీషియా జూనియర్స్ కొలీగ్స్ ఐ టెల్ దట్, see, if a case comes with EF 20%, ejection fraction, and having angina, if anybody wants me to take up that case for CABG, right away with much confidence I can take up. But any patient with a small spotting, full term, having complaining of breathlessness, coming for LSCS, then I have to think of it. Really, I have to think of it. Being maybe almost this is 23rd year of my post-MD experience. Even today, I work up myself whenever I am going to anesthetize any obstetric patient, or if any complaint comes from or if any help is needed in obstetric OT, I'll prepare myself and then I'll enter into that OT. Because what I have to see, what I have to manage, I don't know. What can happen to the patient, I don't know. And at the same time, I have to save the new life which is coming onto this earth. Okay. During my OBG days, whenever we have posted, when we used to enter into our OBG ward, those few of obstetrician teachings used to be, mother is more important than the child. We have to save the mother at any cost. Later on, everything has been changed. That is during 95-96, I am telling. Everything later on changed. Both the lives are very, very much important. We need to have a concern of both the lives. And everyone who are involved from the OP to discharge, they should be much careful and considerate about the two lives. Just let me come into the actual topic. The role of anesthesia in high-risk obstetric patients particularly. The anesthetist is a part of multidisciplinary team, because everywhere you have seen the last panel discussion. ER, OT, ICU. Or ER, OT, ICU, then cath lab, again coming back to ICU. In cath lab, we are there. Okay? There, for embolization, whatever the procedure has been done by our Nikhil sir, we were there. And providing pain relief and anesthesia, which is a much bigger part, because of all the pains, labor pains are the greatest things, but by God's grace, every mother, after the delivery of the baby, is forgetting those pains. Thank God for that. And ensuring safety of the mother and child during labor, delivery, and also any necessary procedures. Suppose normal vaginal delivery is not a simple one. Sometimes severe grade of perineal tears can happen. For that also we need to help, being anesthetist. And acting as intensivist whenever needed. That is, sometimes we may be seeing that the bleeding may not be stopping and the uterus is becoming flabby. Though we have given whatever the IM to be given, whatever the IV to be given, whatever the infusions to be given, whatever the drugs we have given, definitely we need to think like intensivists that most of the times my question is only one thing. Madam, how is uterus? Once the baby is delivered, how is uterus? Is it retracting or intermittent retraction and relaxation, or it is completely relaxed? Most of the times I ask this question to the obstetrician who is operating on the patient. No, sir, it's okay. Madam, anything to be given. Till they start closing the uterus, my blabbering is not going to end with the obstetrician. Because that is my habituation, because I am worried about anything can happen. and watching the monitor, whether there is a tachycardia, bradycardia, or hypotension once even before closing the uterus, because there is a chance of air embolism, and if the patient is under general anesthesia, watching the EtCO2. And also, usually our protocol is having all the monitors attached to the patient, including ECG, 5-lead ECG. Is there any change in the rhythm? Is there any alternate missed beats? Is there any change in QRS complexes morphology? Amplitude is decreased or not? Or is there anything else? And if the patient is conscious, how the patient is feeling? Any nauseating thing? All these things usually I check before uterus closure. Maybe it may take not more than 5 to 7 minutes for the surgeon or the obstetrician to close the uterus after once the baby is delivered. And also, I'll see how is the amniotic fluid. Whether it is clear, mixed with blood, or mixed with meconium. Because if it is mixed with meconium, then I'll talk to the pediatrician. Sir, how is the baby? If it is mixed with the blood, there can be early separation of the placenta even before incision of the uterus. All these things, because if I see blood mixed amniotic fluid, definitely I will check that patient in the postoperative ward, whether patient is having any increased number of change of diapers, most of the times. Because I will call the nurse and then I will ask, because I don't go to that area, basically. Because this is also early indicators, actually may not be written in books. Maybe I am acquainted because of my experience with the obstetric cases. Okay? I do act like that, and my team is also trained for that here.